This is Jerry Nelson. I am from the Orthodontic Division at the University of California in San Francisco. This is part 2 of the presentation I prepared for the CareStream Users Group meeting in Atlanta in March 2014. We discussed in part 1 CBCT in orthodontic practice, and I want to continue this topic. In the second part, I actually will review some of the clinic cases from our clinic. One of the things we talked about is that your radiology technologist can present to you some static images that help you in your diagnosis, but I also emphasize that doing a clear review of your images is really important. Here we have a patient with an impacted canine tooth, and when we start spinning around and looking at the details, then we can appreciate there is no wisdom teeth on the other side, but when we get a better look at the lingual of the patient's right side, we see that there's yet another molar down there on the lingual. So I think scrolling through your images is really an important part of the diagnosis. Let's just review again the field of view that you might use in orthodontic treatment. The largest CareStream 9300 field of view includes Nasion. So this is the 13.5 by 17 centimeter field of view, and it's really appropriate for orthognathic surgery. Actually, I think it's a necessity for evaluation of facial asymmetry. We use the 11 by 17 for orthodontics, the medium field of view. We can see the anatomy from the brain case condyle down to the chin, and we use this view for larger individuals for orthodontic planning. We also take a 2D cephalogram in order to look at the measurements in relationship to the research that's been done over the years. Our 10 by 10 centimeter view is really good for mixed dentition reviews or just for the smaller individual. The voxel size is less than 0.2 of a millimeter, so the detail is really very good. And this replaces the 2D pano and provides a lot more information. Then we take a 2D ceph, our head film, in order to look at the overall profile of the skeleton. A smaller field of view gives better resolution. So what resolution is useful for orthodontic diagnosis? Well, studies have shown that 0.3 or even 0.4 of a millimeter voxel size is really reliable for orthodontic diagnosis and treatment plan. But better than a 0.4 voxel size is, I think, very helpful. And for interdisciplinary treatment, it's really actually quite important. So for interdisciplinary, we usually get the smaller field of view, which is less than 0.1 of a millimeter voxel size, and really the detail, the periodontal membrane, the pulpal canal, all becomes quite visible. At 0.3, none of these, the periodontal membrane is not so visible, but we can see all the roots, and we really can see the bone level. So for orthodontic diagnosis, I think it is really okay. So this is what we would do for that. The 5 by 5 is good for interdisciplinary, and you can tailor these views for the project that is planned, and they're easily constructed just to the best advantage. So should we use the panogram or periapicals as a screening tool? Maybe that's the way to first take a screening panogram and say, okay, do we need the CBCT? And I don't think it's such a good idea. They're very distorted, and the magnification is variable throughout the panogram. The layers of structures are superimposed. The exposure is moderate, 24 microsieverts, but then if you have to add full mouth x-rays or even bite wings, it starts to get up there. And I think when you compare that to CBCT, you're actually going to do more exposure to the patient than your CBCT would have done. And if you take a 2D x-ray, you might still need the 3D. So a lot of lesions will just be undetected with your panoramic because the distortion, particularly around the upper and lower anterior teeth, is pretty bad. I know the attorneys, I've done quite a bit of expert witness work, and one of the first things the attorney does who's suing the dentist is say to the patient, let's go get a 3D x-ray, see if there's anything they're missing. So I do think that that's something to consider. I mean, the families worry about the radiation. It's true. They come in with anxiety. So I think your role is just to educate the patients about what the facts are. Let's look at some panoramic films that might have missed some things that show up in the 3D x-ray. Here's one that has some supernumeraries, and they're not obvious. I mean, are those supernumeraries around the upper left bicuspid area, maybe the upper right molar apical area, or the lower anterior where we can't really see things because they're quite obscured? But nope, they're up near the apex of the central incisors. And now that you have this 3D image, you can see that in the pano, yeah, maybe a couple shadows up there that would represent these two supernumeraries. This panogram shows a lesion, but that's about, well, two lesions really. It's about all you can say about it. But really, where is it? I mean, if the oral surgeon is going to go in and do some treatment, they need more information than this. Which side of the mandible should they approach this lesion? Is it through the cortical plate? So when you take a 3D to view this, you can actually see exactly where these lesions are. This is a periapical of teeth after a traumatic injury. And there's, you know, no real evidence of root. I mean, there's some faint little lines in there, but is that a root fracture? I don't think it's very clear. When we took a CBCT, it was very clear that the root was not fractured, but the alveolar plate was fractured, and that didn't really appear in the periapical x-ray. So when a patient has a traumatic injury to a teeth, a high-resolution CBCT, that's the image of choice in my thinking. This is a great article in the AJODO. And here's a pano. There's a supernumerary in there, but where? Is it in the lower left, upper left? Maybe the upper right wisdom, second molar. Maybe that's why that second molar is so delayed. So let's take a look. Well, here it is in the nasal cavity. So let's go back. That's not very obvious, is it? I think the panoramic really failed to spot this one, but there it is. And I think that's really important for the orthodontist to be able to find that for the patient. Second case involves a root fragment that was left behind after an extraction. There's at least 6 extraction sites here. And the root fragment may or may not be a diagnostic problem, but here it is, up mesial to the premolar, distal to the canine. I think we probably would just go ahead and move our teeth and monitor the situation, but I think it's good to be able to inform the patient before you carry on. In this panogram, there's a temporary skeletal anchorage device that has gotten away from the clinician. It's a mixed dentition patient, so, you know, kind of early for TSAD perhaps, but in any case, the TAD is not where it was first intended. So it's probably slipped into the soft tissue somewhere, and this panel suggests that it's up in the third molar area. But no, it's actually in the sinus and pretty close to the eye socket. So we can see that the panoramic is not extremely helpful there. Here's a case with a fracture in the upper lower jaw condylar area somewhere. Can you really say where it is? I think that it's not as obvious as it is when you take the volumetric image or the slices. This is a patient from UCSF who has a transposed canine and incisor that ran into a bit of trouble. And the CBCT helped sort of resolve or at least address the situation. So the upper left cuspid and lateral are transposed, and the patient has a severe malocclusion, obviously, a lot of crowding, midline discrepancy, really proclined upper incisors, and sort of a normal skeletal pattern. So what's needed here is move those upper incisors back, and that's going to take some extractions. The pano shows pretty good bone levels, but the panoramic is pretty obscured. It's not, the detail's just not there in the area of the transposition. Additional x-rays really would have been a good idea, but they were not taken. So 4 permanent teeth needed to go, and the attending faculty and resident collaborated and took out 3 premolars and the canine, the transposed canine. And the result was that the oral surgeon took out the canine and looked in there and said, wait, that tooth looks like there's some damage on it. So he took a small field of view scan. Look at this yellow line. It represents where this slice is. The yellow line in the upper left represents the slice in the lower right. So I'm going to go move the yellow line, and now we see that there is some root resorption on that central, and move the yellow line over further and we see even more. And now you can see that there's really not much left of the root of that tooth. So what did they do? Well, they went ahead with the braces, just sort of stayed off of the upper left central incisor with the goal that after the orthodontic treatment, that tooth would remain until the child was fully grown and an adult, and at some point it would be replaced. Should we take any CBCTs in the mixed dentition, or should we take routine CBCTs in the mixed dentition? I really think the question there, kind of depends on what exposure you're using, but even the exposure for young children is intensified. So I think discretion is important. Taking scans in the mixed dentition really should rely on your clinical assessment. Well, this kid has a crossbite, and I feel that mixed dentition treatment for any crossbite is appropriate, posterior or anterior. Crossbites can cause tissue damage, wear on the teeth, and even asymmetrical growth. So this patient has some spacing upstairs, mild crowding, and it could be treated non-extraction, which that was the game for him. The panoramic showed that the teeth are oriented okay, a little bit tipped in towards the lateral on the upper right. The upper left one's nice and vertical. And the head film showed that the upper incisors are over-erupted, roots are kind of forward, mandibles kind of back, and he's still growing. So this case was treated with one of Earl's pearls, which is, this is a 17 square NiTi wire that can be flexed in there. It's tied in with the steel wire, and the lingual button is there just to keep this steel ligature wire from slipping off the incisal edge of the tooth. And after 6 weeks, that swings right into place. So that's a really nice technique, but of course as the crown moves over, the root stays behind. And so now the question is, can we move the root forward, or are we going to bump into the canine? So I was the faculty then, and I said, let's get a CBCT before we move that root forward, and we did. The head film that was taken from the CBCT showed that the upper incisor inclination was better, that the tooth had been intruded some, so that's all good, but it doesn't tell us too much about the lateral position. So we're looking at the pano that's extracted from the 3D X-ray, and Well, the upper right canine root is still kind of tipped in towards that lateral. The left one's still more vertical. You can't really tell if there's any damage going on there or any risk of damage. So we got our 3D x-ray and found that, well, in fact, it was pretty obvious to see that the canine tooth is sitting right on top of the lateral incisor. So at this point, I decided, okay, let's just take the braces off. We will correct that lateral position in phase 2 and let the cuspid grow in, let the transition occur. Phase 2, we'll fix the tooth without worrying about the root being damaged. So this 3D x-ray definitely changed our treatment plan in this case. I did mention that supernumeraries were a good reason to use a 3D x-ray, and I would use it in a mixed dentition case like this, where we had some problems going. He has an anterior crossbite, the laterals are emerging on the lingual, and he's got a supernumerary. There's an extra tooth there, and the question is, are there any more? So the models we take shows he's a little class 3 tendency, but he does have a COCR shift, so the class 3 tendency perhaps is a false one. And in the head film, he doesn't really have a class 3 skeletal pattern. In fact, his mandible slips forward a little bit. His mandible is somewhat retrognathic. But the head film image doesn't really help us say anything about the supernumerary tooth. If we look at the panoramic, we can't really see the supernumerary that we could see in the clinic very easily. There's a double image there on the upper right central, so yes, we know there's a supernumerary there. We saw it on the model. But in the x-ray, we find that there's not just one supernumerary, there's actually two. So there's another one up in there. And this definitely wasn't visible in the panel. Let's look back. I mean, yeah, there's a little shadow up there in the midline. That's probably it, but I don't know. It's very visible here. And I think that this helped us because we decided, okay, let's get the supernumerary out that's erupted, but let's also get the other one out while we're at it. And that way the patient only had to go through one surgery. This patient has a supernumerary tooth also. You can see all the crowding, the class 2 molars, and where's the lower canine? It's not there. So we look at the head film and see that the upper incisors are almost horizontal. But we can see the canine tooth in the lower symphysis area, so we can't really see much more than it's there. We can't see that the problem is. If we look at the head film, which is a little bit obscure or not distinct, and we sort of intensify it, we can see there is, looks like there is a supernumerary overlying the canine tooth. And then if we look at slices and go a little closer, then we can definitely identify that the supernumerary tooth there. And if we look at the volumetric even, we can see that there is the extra tooth. So that has to go, as well as some bicuspids in this patient's case. This is a patient with a functional appliance and some delayed eruption. This is pretty ideal for a functional appliance. She's hypodivergent, upright lower incisors, tipped forward upper incisors. Her lower face height can be increased. That wouldn't hurt it at all. She's going to grow that mandible. So she's a really good functional appliance patient in my mind. When we look at the pano, there are some things missing. She's missing the lower left premolar, and then the lower right second premolar is a little bit delayed in its development. So we're going to keep an eye on that. She looks basically symmetrical. What we can see of the condyles look fine. So we gave her a bite opening bionator, which has an incisal cap to prevent the incisors from erupting, but posteriorly the plastic is trimmed away from the lowers to allow the first molars and bicuspids to erupt. So open her facial height and also reduce the overbite in front. So the overjet and overbite is reduced after 12 months or so. The midline's looking pretty good. She still has her retained E on the left and on the right. she's going to need work in the future, obviously. But let's look at the x-rays here. So this x-ray shows that there's quite a bit of overjet and overbite reduction. Face height increased. Upper incisors tipped back a lot. Is the condyle seated? Here's the previous amount of overjet and where we came to. You can see some tipping forward of lower incisors and tipping back of upper incisors. And then we see also the ankylosed tooth on the left and the premolar on the right has developed some root, but the question is now, do we extract now on those teeth or do we wait? Well, we made some decisions based on the x-rays, but first I want to look at the condyles. If you'll notice in this slide that she's class 1 on the right, class 2 tendency on the left. Let's look at the condyles. So the one thing that I see here in this upper left condyle is it's out of the socket a little bit compared to the right condyle, which is really nicely seated. Now remember, I mean to the patient's left. So the patient's left condyle is nicely seated, and that's where she had the class 2. So that class 2 relationship wasn't particularly corrected with this treatment so far. But on the right side, where it says class 1 in the clinic, we see the condyle out of the fossa, and that's probably why it's class 1. If that condyle were seated, I think she'd be class 2 on the right side too. So the family was advised that phase 2 was definitely in the cards. Then we looked at the ankylosed tooth on the left side, kind of interested to see if the alveolar process is being restricted there, and I don't think it is. So we chose to do a little composite buildup just to prevent the upper bicuspid from erupting, and keep an eye on it. We may have to remove that tooth, but I just soon not take it off. I didn't need to. And then on the other side, the question is what to do about the impacted premolar. And I think we've got to get that baby tooth out, because look how the premolar is going off towards the buccal. And we really need to correct the eruption vector of that tooth. So the x-ray was very useful to make those decisions. Alveolar integrity is something that is concerning us at UCSF. I'm convinced that the cortical plate in the front is pretty easily damaged. This is a wonderful woman who really wanted her front teeth moved back. They're protrusive. She broke off the front teeth and wants to have them repaired, and so we need to do some preliminary orthodontics for that purpose too. And you can see how protrusive her incisors are. So the goal is to move those teeth back significantly, and that means that some premolars are going to be removed. Here you can see the wisdom teeth are sort of stacked up at the end. So her 4 bis were taken out and teeth retracted, but as they were retracted, and this is just 2D x-rays, but as they were retracted you can see that the lower incisor roots, crowns tipped back, the roots tipped forward, and they came right through the cortical plate. So now what do you do? So I wasn't attending, but the attending said, we better get those teeth tucked back into the bone. So they continued the treatment, tucked the lower incisors in, and started intruding the upper centrals until there's room for the restoration. And she's now nice class 1, nice improvement in her facial appearance, and the roots are nice and parallel. So this is a nicely treated case, but the interesting thing is that the lower incisors are tucked into the bone, and the bone actually, you can even see, has formed over the facial of the incisors. And here's her before and after pictures, and then here's the before the restorative and then the after restorative. So that came out really nice. She was very happy with that. The next case is when teeth are very crowded still after a serial extraction, and the correction worked out really good, a bonded retainer placed, and then the patient gets a habit of playing with their lower right canine tooth, pushing against it and pushing the crown in. It rotates around the bonded retainer, root goes labial, and this is pretty amazing. Let's look at the radiograms. This was published in the AJODO. The root came right through the cortical plate, and if you look at the slices, you can see in the lower right cuspid even the alveolar nerve traveled along with the root. So the orthodontist said, let's deal with this. And they retreated the case, moved the root back into place, and actually the bone healed around that area very nicely. Another thing we worry about is, are we safe to expand our cases, and are we going to run through the cortical plate? And I really think this is something we need to pay attention to, both in transverse expansion and in proclining the lower incisors. In surgery cases, we like to procline lower incisors prior to surgery so that we can position the jaw in the best way and still have a proper overbite and overjet. So we kind of make the underbite worse before we can make it better, of course. And you can see the amount of decompensation in this patient that one does, and you can also see that the symphysis is pretty thin, and there may not be much bone around those teeth. Well, I was involved with my colleague Seung-Hun Kim and Kyu-Rim Chung, and in this case where they did some corticotomies, you can see how thin the bone is, bone grafting, and replace the tissue, and then to procline the teeth. And the bone healed around those proclined teeth pretty nicely. And you can see from the start in the upper left how thin that symphysis was. Once we get out there, there's plenty of bone, and it will remodel to a smoother area. This next case is a UCSF case about 10 years ago that required surgery, and it turned out to be upper and lower jaw surgery. 4 bis out, and lower teeth are tipped back a lot, so they're going to be tipped forward prior to the surgery. The bone levels are all, as healthy as they should be for a young person. She had posterior crossbites, a collapse of the maxilla, underdeveloped and laterally and sagittally. And the treatment was completed with reasonable occlusion, but not ideal. I mean, it wasn't really a great finish occlusally, but lots of good facial change, and the pano looks decent. I mean, you can see the bone levels aren't bad. And then when you look at the head film, this is right when we got our first CBCT, and the attending looked at this and said, whoa, it doesn't look like there's much bone there. Let's get a 3D x-ray. Here's where what the bone looked like before treatment. And then after treatment, you can see the symphysis is really skinny. So looking at the x-ray, we found that the lower incisor was just basically perched on top of the symphysis. It's my opinion that we're kind of ignorant about the limitations of tooth movement in the alveolus, and we in the past moved our teeth with not worrying about the cortical bone. And we are doing some research which I hope will shed some light on this. So this gal definitely wound up with some problems with those lower incisors. Sometimes teeth do get away from you. My son is a doctor who sent me this article from the New England Journal, and tooth in the sinus. I thought that was pretty interesting. It had caused the sinus to actually get deformed, remodeled, and also caused a fistula. That's how they discovered this whole thing. And you can see how the septum is kind of displaced by it as well. This is an adult who had a double protrusion also, and wanted to have the teeth retracted. And so the question is, what about the alveolar housing? Well, the lower alveolar housing looks pretty okay. The upper looks worrisome because it looks like there's not much bone over those roots. She had fluorosis. I don't know if you saw that. She had quite a bit of fluorosis because she was in a high fluoride area. And so 4 bis were taken out, and the teeth were retracted using TADs, even though the sinuses are pretty invasive in those roots. And you would think, put a sinus in there, put a TAD in there, it's going to be in the sinus. And I think it probably was. Again, this wasn't my case, but this is how much protrusion there was. So the correction came out with a pretty nice result. I mean, it's occlusively, it's not great, and believe me, we do some really great treatment at UCSF, and I'm showing you some of the ones that are less than ideal just for instruction. As you can see, the TADs were placed to retract the teeth, and however, you can also see that there's a lot of tissue display, and so those upper incisor teeth maybe could have been intruded, and also the roots don't seem to be retracted as much as they should be. But she was, happy with the appearance, the change, but again, I just feel like the upper incisor position is problematic. But the other issue is she had some pretty severe root resorption. And one of the things we know about root resorption is when you move teeth into the cortical plate where there is no vascular supply, it's a problem. And I think the roots will cave before the cortical plate does in a lot of cases, or at the same time. So I think in this case, the reason that she had so much root resorption, and here is just, she'd had a little bit on the lower, but not as much. But when we look at the slices, we can see that the upper incisor roots, as they were retracted, really there just wasn't enough bone. So they're perched on top of the cortical bone as it is. Lower incisor roots looks like they have a little more support. But I think that the root end resorption is really a result of contact with the cortical plate. Here you can see the upper incisors are tipped back. There's no loss of anchorage at all. But the upper incisors, instead of being intruded as well as retracted, just tipped back, and you've got some resultant extrusion that demonstrated more gingival tissue in her smile. Here's a case where there's some asymmetry, and there's actually a supernumerary in here too, which we'll get into. But when you see asymmetry like this, you have to say, okay, is there a COCR discrepancy that would change what we've got here? You can see that the lower midline seems shifted off to the right. She's got a crossbite on the right side, mild crowding, and a class 2 molar on the right. So we look at this head film that's taken from 3D, and the skeletal pattern looks pretty balanced. At this point, just looking carefully, we see there, it looks like there's a supernumerary there. But the question is now, if we're going to put braces on and move these teeth around, are we going to bump into that? Do we need to get it taken out? Is there any concern? And here we can see the supernumerary in the panoramic, and in the AP head film, you can kind of see it as well. And also you can see that the patient's jaw looks quite asymmetrical. The midline's off, the crossbite on the right side. Let's look back at the head film. We can't really see too much from the panoramic as far as the condylar position. So a good look at the condyle would have, I think, been good with this case. So we took our 3D and sort of looked at things rather carefully, because the real question for me is, okay, I've got the nerve up here, the anterior palatine nerve coming through the bone. I've got my supernumerary tooth. Let's just drag our purple line and make it at an angle so we can look at the cross sections right along the axis of that central incisor. Most of these programs have a way to either rotate the picture or rotate the x-axis. And now we can sort of pass along that area, see how the yellow line's moving, and then you can see exactly where the nerve and the supernumerary is located. And then once we have got that, we can zoom in and get a better picture of it. So in this case, we thought, okay, these things look too close. And the oral surgeon said, I don't want to take out that tooth. You're just going to have to risk that there might be some root resorption. So that was the decision that we made, was to not take the tooth out and just go ahead with the orthodontics. So we did we're concerned about the COCR discrepancy, so we made her a splint to wear for a few weeks and would see her every week and adjust the contact points until she kept coming back with the same contact points. And then we knew that we were there, and you can see the midlines have lined up. So the unilateral crossbite that she had was really not so unilateral. But the class 2 relationship on the right side was still something we had to deal with. So she's kind of class 2-ish on the right. There's actually still some space here. So if we can just drag forward that lower right, not move back the upper right, that would be good. So we put a TAD on the lower left and started moving the teeth forward on the lower right. And that worked out really nicely. The end result was good. She actually doesn't really look asymmetrical anymore. But what about the supernumerary and the central root? What happened to them? Well, as you can see from the CBCT after treatment, the supernumerary and the palatine canal are still adjacent to each other, and the supernumerary tooth in that lower view, you can see that there was a little bit of root resorption, but certainly not enough to get too worked up about. And what about the asymmetry? Well, she still has a little mandibular asymmetry, but not really much, and certainly facially it doesn't show up at all. So this worked out, I think, well for her. I think it's just one more case that shows the value of 3D x-rays in treatment planning. So just to wind this up, I do believe that 3D x-rays are very valuable. It helps us make a better diagnosis and treatment plan in so many cases. I do believe that using the panogram as a screening tool is just probably not adequate. I don't really think it's a good choice. I do advise the family of the risk of not using a 3D x-ray, and then we scale the field of view and the power according to how we see the patient's need. And then we use the dental radiologist as we need to. I'd say about 30% of our cases we send the films off to the radiologist for reports. Well, this ends the presentation. If you have any questions, please contact me at this email address. If you've got a URL reader on your, or QRL reader on your phone, you can snap this picture. It gives you my contact information. And I hope you enjoy your day. Very good. Best wishes to you all.